Good afternoon and welcome to Internal Medicine Grand Rounds. There is no commercial support for today's program. The speaker and planners have disclosed no relevant financial relationships with any commercial interest. If you have a question for the presenter, please hold until the Q&A segment at the end of the talk. And if you're attending virtually and have a question, please enter it into the Q&A chat. Also, a link to the event survey will be shared at the end of the program. It is my pleasure to introduce our guest speaker today, Dr. Femi Olukayode. Dr. Olukayode is a PGY3 resident and graduate of the American University of Antigua, currently completing his training at Northeast Georgia Health System. He aspires to pursue a fellowship in cardiology with a strong interest in a holistic and patient-centered approach to cardiovascular care. His clinical philosophy emphasizes shared decision-making grounded in current evidence and established guidelines. He brings additional experience from his work in commercial clinical research across oncology, cardiology, and general medicine, which further informs his evidence-based practice and dedication to advancing patient outcomes. He is supported by his wife and 3 children who keep him grounded and motivated as he progresses in his medical career. Please join me in welcoming Dr. Olukayode.
So we'll be talking about the Statin Controversy. One of the reasons why this topic came to mind, so I've gotten an opportunity to speak to different clinicians about their, I would say, ideologies, what they consider the evidence-based medicine regarding statins. And then I found out that if you kind of delve into PubMed, kind of just inquiring about, statin guidelines, there are a few established guidelines that, that we are currently operating under. But you'll be, you won't be shocked to find out that there are quite a lot of, some physicians who do not even believe in statins, or they believe they are, fraught with peril, citing maybe, the pharmaceutical industry or what they believe to be the actual benefit. So I kind of spent a few time, some of my time going through several researches that have been published regarding statins, and just want to have like a discussion and see where we go from here. So I have no disclosures, to share with you. So I think that will hopefully make me an objective observer regarding some of the trials that we'll see on statins. A few contents that we'll be going through, cholesterol and cardiovascular risk, statins mechanism of actions, at the atherosclerotic process, several history, and I think it's been quite a very extensive history of statins. And then the controversies, big pharma trying to delineate facts from fiction, the types of statins, and hopefully at the end of the day we could all come to a conclusion. Do they work or not? Tolerances and side effects, and I think ultimately our goal today will be to get to a shared decision-making approach with our patients whenever we discuss statins. There's been quite a lot of research. I think this could possibly be one of the most researched drugs and processes you could find on any modern database at this time. This is a study in 2022 just trying to establish cholesterol and cardiovascular risk. So this is just cholesterol. We're not even talking about statins yet, because again, cholesterol preceded statins by, I think, a few decades, and statin was meant to be the antidote. So this is a meta-analysis in 2022 with a forest plot looking at looking at serum cholesterol and associating that with cardiovascular risk. As you can see, we see increased hazard ratio with a confidence interval that's acceptable, that increase cholesterol, which is the total cholesterol, can be associated with increased cardiovascular mortality. Again, here we're looking at LDL-C in particular, and that also, which again, the same meta-analysis study, that also is associated with an increased hazard ratio and with acceptable confidence interval. HDL, as you know, I guess popularly known as the good cholesterol, if you're gonna have cholesterol, might as well have the good kind, is HDL, and that has been That has been researched, and I don't think there's any controversy that HDL is good for us, and there's really no upper limit, and that is associated with lower cardiovascular risk. So again, the main ones we're talking about, again, total cholesterol, LDL, HDL, those are focal points. But in 1913, which was the first time, cholesterol was described by Rudolf Virchow, and they thought of it even at the initial stage as an inflammatory process, even though they did not understand the process at the time. And if you look at any, inflammation, any pus, just look at the type of, I guess, exudate you see. So imagine taking a look at, cholesterol accumulation either within the arteries or within the cadaver model. That was thought to as well. This could be an inflammation. It was just thought of as a fatty yellow substance. But then later down the line, after further, research, it was then classified that this is cholesterol, and then of course we have what we have today. But because of its association and belief that this is associated with cardiovascular risk, this kind of ushered in the Framingham heart study. This is a study that was commissioned by the U.S. Congress in 1948. So this has been something heavily legislated even in this United States. 5,209 subjects were enrolled. And of course, Framingham is a city, I believe, in Massachusetts. And the study is currently right now on its third generation, as the progenies of those initial patients that were enrolled are still currently being observed as a way to kind of learn more about how cardiovascular benefits or risk has its root in cholesterol. Of course, major findings. In 1960, we have smoking and obesity being associated with heart disease. And of course, we also came to the idea that getting off the couch and doing a few exercises could benefit us. Hypertension was associated with stroke in 1970, and all of this was all from under the Framingham study. 1980 was when we came to the idea that HDL was inversely associated with heart disease. And in 2000s, pre-hypertension was something we started to look into. Again, elevated serum aldosterone as one of the secondary causes, and of course, obesity as a risk for heart failure. So the Framingham study has been something that has been heavily looked into. But of course, if you go online and do a little more research, there's still a few controversies as to if they think it's beneficial or not. But I think as a working thought process, we will say it has at least given us quite a few positives and added value to the healthcare industry. Just kind of taking us a little down memory lane with regards to what we call apolipoproteins. Some of us who still remember in biochem. These are kind of the major ones that are within us, right? So you have the chylomicron, which is heavily it's mostly let's see, triglycerides, right? So our carbs, if you eat any heavy carb diet, you have that turned into chylomicrons, going through an uptake mechanism within the intima of the guts, and of course this is transported to the liver for processing. And we have different types. We have the chylomicron, we have the VLDL, IDL, LDL, and HDL. And just looking at the different charts here, the yellow being the triglyceride, and the orange, which is the cholesterol. So you could just see how as you kind of go down, and as the chylomicron pretty much reduces in size, when the triglyceride are taken from the chylomicron and used for energy purposes, the density reduces, right? Or rather, no, I say the density increases actually. And all of this are markers, apolipoprotein markers, A, B, C, E, and those are markers that kind of help them get to their targets. And you can see where they are produced. Again, chylomicrons in the gut, VLDL, high DL, LDL, also in the liver, and HDL is a combination of both. So just kind of giving us an idea of what we're talking about and what these structures look like. Looking at functions of these different apolipoproteins, like I said, HDL is considered good because of its function. So it does esterification of cholesterol, helps with uptake of cholesterol. It's also a reservoir for apolipoproteins. Now, these are needed for uptakes of different types of cholesterol molecules, and of course used appropriately. LDL functions more so, again, for cholesterol transport. That is about 50% of cholesterol. If you take a look at that slide, it accounts for about 50% of cholesterol. Now, I'm not saying that cholesterol is bad, it's just saying that, HDL is the one that kind of has a higher volume of cholesterol. Of course, it's used for adrenal gland processing, sex organs, and in as much it makes it through from the gut to the liver, no problem. As part of most of us in the clinic, one of the things we look for right now where a lot of guidelines are built is through LDL, and we have two types, LDL-C, and then we have the LDL-P. So LDL-C is LDL cholesterol, the LDL-P is particles, and the way we kind of differentiate, because in the clinic we pretty much just do the LDL-C. It's only probably under special circumstances that we'll probably check for LDL-P, which is the particle. And we use this because based on the research that we've done, we see increased association with cardiovascular risk, and the goal is to kind of help reduce that. At least that is a working thought process as we go through this presentation. For the LDL-C, if the numbers are below, I believe, 130, no problem. But we've seen situations where there is what we call, what's the word I'm looking for here? Discordant, where you have a normal LDL-C, but then you have increased LDL-P particle. And the way to kind of think about the two type of LDLs is, so for a patient who has 150 milligram per deciliter, the LDL to your left will be the pattern A, which is just LDL-C, looking at the concentration of cholesterol within the LDL, while the other one looks at many particles of LDL, but decrease concentration of cholesterol. So both of them have the same number of cholesterol, but you have more particles of LDL carrying those total cholesterol. And that's the way to kind of look at, LDL-C and LDL-P. So I got a question here. Which of the following is associated with atherosclerosis development?
Are you wanting us to answer the question?
Yes, just shout it out
Okay.
if you can.
I need to phone a friend.
Anyone going with A? B? Okay. C? No one? C, really? Okay,
We're
how
going to go
about D?
C.
You got C, okay.
Going C.
Going to C, okay, all right. Okay, the answer here will actually be apolipoprotein B. Apolipoprotein B containing lipoprotein. So if you remember the initial slide that I kind of showed a little earlier, just kind of backtracking. Many of the apolipoproteins that we have here, you have the A, the B, you have 48, C, and E, our concern when we look at cardiovascular risk has always been LDL. But LDL is not the only problem I would say that we have. Apolipoprotein B here, which is the marker, one of the proteins that is attached to VLDL, IDL, and LDL, what they all have in common here is apolipoprotein B. And based on research, we've seen more concordant data that apolipoprotein B seems to be more predictive value of association with cardiovascular risk, not just LDL alone. I know within our clinics we do not check for VLDL. I don't think we do VLDL anymore. I haven't seen that in some years. LDL is not a common value that we look for. LDL just seems to be the main one, but apolipoprotein B is the main issue, and sometimes the reason why that is this process right here. Like I said, LDL in itself is not the problem. The problem is having cholesterol deposited in the wrong places. So just think of apolipoprotein B as the dump truck, right? And its only job, is to get the cholesterol particles from wherever they might be within the gut, within the, within the muscle, back to the liver for reprocessing, repackaging, energy storage, and for reuse. But what we then see is along the line, sometimes, the apolipoprotein B, which is dump truck, could often become faulty. And rather than get the cholesterol particles to the liver, it just dumps it along the way. And that's what you see here, where you have also, maybe sometimes, rather, which is a walk-in thought process, with increased LDL and its association with cardiovascular disease. The more you have an increased LDL, we believe, based on the research, that leads to cardiovascular diseases. So the concern is there's so much cholesterol particles that the apolipoprotein B cannot get them all to the liver, in time, and they often just dump them along the way. And then that kind of lead to a cascade leading to inflammation processes, and then, of course, atherosclerosis development. Now, one of the non-controversial statin uses that we do know and agree upon at this point is patients that have autosomal codominant losses where they have LDL receptor gene, which leads to apolipoprotein B uptake, and these are seen in patients with familial hypercholesterolemia. And of course, these patients come in having significant elevated LDLs, and I think at that point in time, there's no controversy that we need to lower this patient's statin because it gets to a threshold that we must reduce those numbers and, of course, treat the patient so as to reduce cardiovascular risk. So we do know increase of LDL cardiovascular risk. But we also have patients that are heterozygotes, familial hypercholesterolemia, and this has an incidence of 1 to 200, 1 to 300 worldwide. And of course, you see this patient presenting with LDL rather in a young, in teenagers, those in their low 20s, where they have LDL from 173 to 463. This is pretty significant for somebody who probably has a BMI of 25. At this point, you start to worry that something else is going on and something must be done. And we also see increased cardiovascular and premature cardiovascular risk, even in childhood, for any of these patients, those with the autosomal codominant or those that have heterozygous familial hypercholesterolemia. Say that 4 times fast, it's just difficult. Anyway, we have LDL, of course, greater than 190 with a strong family history of xanthosylema. When you see this patient again, you want to make sure that they are treated. I don't think no one has any concerns or questions that should be done. So this is one of the things that I think we should think about. And I know most of us don't see pediatric patients. But if you are to see anyone in their 20s with those elevated numbers, I think we need to start thinking about, familial history and how to take care of that as soon as possible. Plaque formations, which is the harbinger into atherosclerosis development, right? You have increased LDL, plaque formation, and then cardiovascular disease. The process is, endothelial injury usually can be the triggering factor. So you have patients that have uncontrolled hypertension, disruption of the intima layer of the blood vessels. You have increased permeability because of the inflammation process. You also have increased flooded LDL particles within the bloodstream. That, again, this is a recipe for disaster. LDL also has, electrical charge and affinity to translocate within the intima and get into the blood vessels and cause damage. The size of it also matters. That's why when you have patients with increased LDLP particles, where the LDLs are there, but they are low concentration, rather than the LDLs which are bigger, which have difficulty passing through, that is where you see LDLP even being more of an increased cardiovascular risk because of its size compared to the LDLC, which is probably bigger compared to when you have increased particles. That also causes more trouble, and again, as a recipe for plaque formation. Cholesterol enrichment, again, more cholesterol is associated with more cardiovascular risk. Oxidation process, again, leads to more inflammatory response. This is just a pictograph of the process, the 8-step process that we'll see with atherosclerosis development. And as you can see, the step 1 process is the presence of LDL. There is no LDL, chances are you probably wouldn't have any atherosclerosis development. And we've also seen research where patients who have genetically are predisposed to having low LDL have significant risk of atherosclerosis and plaque formation over their lifetime. But again, as you can see, this is not just the presence of LDL. The monocyte activation, monocyte translocation, scavenger cells, foam cell formation, activation of interleukin-1, also activation of interleukin-18, works together in a synergistic approach to lead to, plaque formation, not just the presence of LDL alone. So the pathophysiology is a two-pronged process, meaning that our response should also be a two-pronged process, not just a reduction in LDL. However, it could be a critical stake in the process, but we cannot ignore the inflammatory process in our treatment approach. So enter statins, right? So like I said, 1913 was the initial time when we had the knowledge of atherosclerosis. And it took several decades, I believe 1970, for us to have the first statin in open market, which is used. And the process, again, many of us are aware, which is a critical step with the reductase inhibitor to kind of just help reduce production of cholesterol. So the less cholesterol, the less chances of having atherosclerosis development. But the concern also is that if this is a normal biological pathway, there are also benefits of having cholesterol, right? So we use them for steroid hormone, vitamin D processes, bile acids. So just blocking this process, again, is something that many people are concerned about and say, well, what about the side effect if you're blocking this natural process? But again, this is more so used in patients who have, too much cholesterol. We're trying to just reduce those numbers. So, like I said, 1970 was when we had the first statins, and we're currently using it to this day. Current guidelines for statin use, looking at patients with, again, cardiovascular risk, diabetes, CKD, and greater than 10% when we kind of look at their cardiovascular calculation risk. Our expectation, and if anyone has rotated through cardiology, is they want to have, patients below 55 for LDL. And for patient with cardiovascular risk, the guidelines is currently to have LDL less than 70, and then of course, and of course, for patient with moderate risk, less than 100. That's been the guideline since 2019 that we are currently working with. So, main functions of statins, again, is to disrupt cholesterol synthesis, plaque stabilization by shrinking the cholesterol core, because cholesterol enrichment is associated with inflammation, leading to the cascade. So reduction of the cholesterol leads to reduce inflammation and reduce plaque formation. And then we have anti-inflammatory effects, but also I had it here, pro-inflammatory process, because statin has a pleiotropic response, and where it kind of does both. But it seems, based on the research and the benefit, that the anti-inflammatory response seems to be more so dominant compared to the pro-inflammatory response. And the process, based on the research that we do have documented, is through the PXR activation. And the way statin does its anti-inflammatory process is by inhibiting the NF-kB binding to NLRP gene promoter, and this reduces the expression, reduces the cascade. Also, the TLR and NF-kB suppression is also another one. And then, of course, improving nitrous oxide production, again, helping blood flow, reducing irritation or inflammatory process, improving turbulent flow within the intima. Again, all of this, the anti-inflammatory response that we see as a benefit. We also have documentation of pro-inflammatory response. We do believe that when we inhibit the mevalonate pathway, that this could also lead to interleukin-1 beta release, and also has increased inflammasome. But this, again, is still being debated, but that is what the research says at this point. We also see NLRP inflammasome activation in vitro research, but this is at a higher dose, like 500 to 1,000x doses of statin, not the type of dose that we use in our patients. We also have records of some specific statins, atorvastatin, for example, having shown to induce inflammations and caspase-1 activity, but we do not have any in vivo studies. So many studies, like I said, probably one of the highest studied drug with conflicting data, and sometimes we need to kind of review both evidences and see which supersedes which. One of the studies that I came across was the pharmacologic dose of atorvastatin that induces inflammations. What you see here is that at 50 to 100, you have mild activity of that's the caspase-1 activity, and at 1,000 milligrams you see a significant increase. But again, most of atorvastatin doses are between 40 and 80. But again, that little increase is, some consider that to be concerning, that could also lead. But this is just for atorvastatin. When you look at atorvastatin, you do not see any increase in inflammatory process through the caspase-1, but when you go to 200, you could see some of this effect. But again, these are not the kind of doses that we use. But I think it's important to mention because, like I said, the controversy is there, and many researchers believing that, well, statin is not doing what it ought to do, and that it's not helpful. But again, all we can do is look at the data and make our own choices. So, again, side effects, benefit, risk, pharma profits. I just kind of put this into ChatGPT and just give me a picture that shows confusion. And this is what you see. And that's kind of like the state of the way we see statins. And I think, in my opinion, and I think you could also look at research, at least some of us in the clinic, you can see statin is one of the medications that you have high rate of non-compliance. So you start a patient on statins, maybe either after a cardiovascular event, or as a preventative measure. especially those when you calculate the ASCVD greater than 5 or greater than 7%, they will tell you, well, do I need to take it? Well, I've read this or I read that. And some of the things they will tell you will be, I heard it causes muscle pain. I heard it causes memory issue. And I think sometimes the way we communicate with the patient leads to some mistrust sometimes. And the reason why is because there's a lot of misinformation about statins. So they come with their preconceived idea, and then we just say, hey, you know what, just take it. That's just the evidence, that's what the guideline says, just take it. And they don't seem to trust us because I think sometimes there's a breakdown in communication when we try to tell them about statins. All right, so I got a question here. What variable is important in considering overall cardiovascular risk? Is it just the cholesterol level? Remember we said enrichment of LDL causes cardiovascular risk, at least based on our recent review, or is it time of exposure to cholesterol or A and B?
Hold on, we're phoning a friend. What do we think? C, A and B.
Okay, all right. So I have here, and we could debate this. We could debate this. I have here as time of exposure to cholesterol, and I could debate you on that. But here's the reason why I came to that conclusion, and we'll talk about that very soon. What we know is that based on many research, there's a many meta-analysis, that you have this inverse line that the lower the LDL is, you see that the lower the cardiovascular risk. Like I said, there's no doubt, at least we believe that, I guess the question is for you to answer. Do statin works? And this is the research, this is the evidence. Do statin works? And then again, many of these studies show that when you have decreased LDLs and decrease, based on the hazard ratio, decreased cardiovascular. But one thing that we also found out in the research is looking at time of exposure. So, patient coming for an annual physical, one of the things we do is, check cholesterol level. I believe the current guidelines by CMS is to check lipids every 5 years. But sometimes I think if you have any reason to believe that they have increased LDL, we often just do it, I guess, based on our discretion. But the meta-analysis show that there's a 23% lower risk of cardiovascular event for every 1 mole per liter, millimole per liter, which is about 38 milligram per deciliter, when we looked at about 26 studies. And of course, about 170,000 individuals were pulled from this study. And this graph is meant to help kind of look at, let's say a patient, this is a starting point. And you have a patient, let's say at the age of 18, the total cholesterol was, or LDL rather, because this was just looking at LDL. So you have the patient having 200 at the onset, at the age of 18, and they just kind of stayed there. They did not, it wasn't reduced. Over time, what we see is that it gets to a critical mass, where we get to the point where cholesterol or leads to atherosclerotic vascular disease. And then you see a patient here who has between 120 to 180 from the age of 18, and you just kind of watch them. Eventually, they will develop atherosclerotic disease, but it will take them a longer period. And then compared to someone maybe via genetic predisposition, or just having a good lifestyle, eat the right things and exercise, and their cholesterol values between 100 to 140. Based on this research, we see that eventually they also will, the heart will give up at some point. But chances are that will occur somewhere, 140, if they're still alive at least. So the thought process here is that exposure is a function of dose over time. Meaning that we need to look at not just, getting, late to the game, but being behind the cue ball, where we have a conversation with the patient and kind of explain to them what the process is, and that reducing your risk earlier on, per guidelines and per research, potentially will give us a better benefit. Now, let me see here. So this is the study looking at cholesterol lowering therapy, and the main result from this study is that lowering LDL-C is greater if initiated at an earlier age, as opposed to someone starting at the age of 50 or 60, because now they've developed cardiovascular events or a stroke, or now they're showing up to the physician and you're looking at the LDL at 210, 220. At that point, the idea is not that it's late, but at least you're late to the game. So part of the study, you can see here, the study was done for over a period of 5 years. So I mentioned earlier that you have a 23% reduction. If you reduce a patient's LDL for per 1 millimole, which is 38, so the patient comes in at 150 and that was reduced to 120. The calculation is that after a year, you have a 12% reduction in cardiovascular risk. The study was done for 5 years, and it's the reason why we have this number. But when you then go ahead for, let's say, over a 7-year period, lifestyle modification, the numbers were the benefit compounds, and the expectation is that the risk reduction will be at 29%, and over a period of a lifetime, you could have up to 54% reduction. And so let's say someone here looking at the green fella here, who kind of started like, let's say, about 180 milligram of LDL, and then we get to a point where, let's say, we start them on starting at the age of 35. The idea is we could change the trajectory. And of course, this has to do with compliance, patients, shared decision, understanding what they are walking towards. I think through that process, we potentially could actually, cut, through the noise and get through to most of our patients who have reservation with statins. This is a popular, I think this was like in the 90s, early 2000s, of Lipitor commercial, and it's used by maybe many YouTubers, many researchers about what they believe, even some patients, what they believe to be the misinformation. So as you can see here, it says Lipitor reduces the risk of heart attack by 36%. But then, of course, you have to read the fine line there, and if you read the fine line, which is difficult to see, well, I guess I will have you answer the question based on this. I'm glad y'all can see it. So let's say this is your patient, and has come to see you after seeing this commercial, right? It says, ask your doctor if Lipitor is good for you. And out of the 100 people, out of the 100 persons that are treated with Lipitor, and the patient wants to ask, how is this beneficial to me? Based on this result, based on that commercial, what would you say? Like, out of 100 people, which one of this would you tell your patient benefits from statin? Is it 36 people out of 100? 67 people, 1 or 6? No one?
What do we think?
A, B, C, or D? Come on.
Gotta have a guess, guys. Come on.
Any guess. I will take any guess.
I can't hear you. A?
A,
Going
okay.
A.
So we're going with A. All right, so some of this could be misleading. The answer is C. So what was popularized back then was the relative risk, right? But we have to look at the absolute risk. So the way this study was done, when they compared, and if you could, it's just this was the best picture I could find. What this says is that in a large clinical study, 3% of patients taking placebo had a heart attack compared to 2% of patients that was taking Lipitor, right? So you have 100 patients, 50 had Lipitor, 50 had a sugar pill, and you had 3% cardiovascular risk in the placebo group, 2% cardiovascular risk in the Lipitor group. So how do you calculate the absolute risk, right? The absolute risk will be 3% minus 2%, right? So that is not the opposite, sorry, the improvement in the benefits per se. What does the patient get? So out of the 100 persons, you have to treat, only one of them gets the benefit, right? 3% to 2%. The difference gives you the absolute risk. So when some of the patient, I guess, found out, or some of the researchers, based on their approach to interpretation of clinical data, saw and say, well, if it's just one person out of 100, well, is that really beneficial when you look at the potential side effects? So that kind of became some kind of, I guess, confusion and debate within the medical community. And I have this little example to kind of help illustrate absolute risk with relative risk. So we have a vehicle. Let's say, Allstate called you and say, well, I have this DriveWise app, and if you plug it into your car ODB port, it's known and is expected to reduce accident risk, right? And you drive, and the way they did their testing is they drove 1,000 times around the block, and the car without the device had 10 accidents, and the car with the device had 0 accident. Okay, so when we look at the risk, remember, 1,000 times around the block, 10 accidents compared to 0 accident, the risk is 1% compared to 0%. So the way we calculate this is that the absolute risk is 1%, but the relative risk is 100%. So it depends on the way the data is published, because the way we got the 100% is here, 0, meaning that no accident. Here we have accident. So this device, when we look at 100 times driving around the block, eliminated all form of accident, meaning that it reduced accident 100%. Now, when we look at that same device over a 20-year period, right? So same device, and let's say we assume that the 1% has now ballooned to 50%, when we calculated the data over a period of time, and the device is still 0%. The way you interpret the data is, well, the relative risk is still 100% because the device is still eliminating all accidents, but the absolute risk is 50% reduction. And I think those important, we need to be able to discuss both type of data when we make our assessment, especially reviewing any form of pharmacological data out there. So now, this is a chart, and the black line is placebo, and the red line is addition of any substance. And the patient is between 45 years and 50 years of age. And if you look at this data, you say, well, I don't really see a lot of benefit, right, from 45 to 50. But again, there could be potential side effects. So some patient or some clinician will say, well, the benefit is very minimal. I don't think it's worth the while. But if you then go and look at the data, that same data that I talked about was more so the smoking effect and lung cancer, right? So someone smokes, and we look at their cancer risk between 45 years of age and 50. It's pretty, I wouldn't say, some could say it's negligible, but then when you look at it over time, now maybe this might be a little bit of a hyperbole, but you could see that it increases with time. And that's the way, we kind of want to look at statin, the risk, and look at the context going forward. Another thing that we've also thought about, or that has been popularized, is that, well, how much benefit do you actually get from statin in terms of, addition of life? So statin only has about average of 10 days to your life expectancy. Would you say true, or would you say false? False. Okay, all right, we got this one. Okay, good. This was a study that has been scrutinized where they believe that statin only had it about 3 days of life. And then after reaching out to the writers of this study, and what they came to was that they've only estimated the survival gain achieved within the trial's running time. Trial ran for about a year, and for about 5 years actually, but no one died. But then they came and published and said, well, maybe it only has about 3 or 5 years to your life. Now, when someone reads that and say, well, just 3 to 5 years, and I don't have to care about diabetes, myalgia, or any potential side effect, I think I'll pass. But this was a trial that needed to be heavily scrutinized. When we look at the underbelly, it really didn't provide what a clinician will consider, I guess, benefit or appropriate process. Many other trials have been done with varying degree of results. We have 8 to 17 days as a benefit, which is still being scrutinized. There's a 4S trial that shows that the 1 year postponement is between 1 and 5 year postponement of that, meaning that we think it could add up to 1 year. There's another long-term analysis, because statin is still, in that early phase. Again, started using it in the 1980s. Currently, right now, most people have been taking it for about 20 to 25 years. We have a wide margin here, and this was on the simulated data for a 20-year trial, saying they're estimating between 3 to 10 years of benefit. And then they did a genetic measuring test using the apolipoprotein B. They're thinking that there's probably a 2-year benefit. And then we have the legacy effect. Statin has been used now for about 20 years, and they think that about 5 months improvement in livelihood is probably what we have. Now, again, there are many numbers here, and they kind of vary widely. And I think what is important is that it varies from persons to persons, and everyone's baseline and risk factors and comorbidities varies significantly, and we cannot just use those numbers alone to make the decision. Some of the facts and myths and side effects that make a lot of patients not want to go on statin, or while some physicians think it's probably not worth the risk, is memory loss. And we do have an animal model where they can look at mouse, and they did a post-TBI, which is traumatic brain injury, and they look at, and they added statins to this mouse model, and they came to the idea, and this was a study that wasn't well done, at least based on the research, but they're saying there could be potential memory loss. But then we'll come to the human model, looking at the pharmacodynamics on the belly of what statin does. Again, we found out that increased cholesterol is associated with increased amyloid synthesis. So if we reduce cholesterol, we should have decreased amyloid synthesis, which again could potentially have a benefit with memory loss. But also we see some observational study that shows reduction in dementia. We also see prospective studies showing no cognitive benefit at all. So again, the result goes all over the place. You see, for every data point in statin, you will see a data point or a research that supports the claim, or you see one that say, well, I don't think there's any benefit. And I think that's one of the issues, why we're having this conversation. Most common side effect is the statin-associated muscle symptoms. When a patient comes and say, well, I'm having, body pain, leg pain, cramps, and I think it started when, you gave me statins. Research so far have shown that possibly is about a 10 to 25% incident rate, but this has been debated. The Procedure study shows about a 9.6% incident rate, and it seems to be a little higher in women. And of course, with age greater than 65, we see a 10.5 to 8.2% incident on a p-value of 0.01. So I think there's some evidence that, yes, there is some myalgia associated with statin. In 2015, the STORM trial looking at atorvastatin at 80 milligram shows that there's some mild elevation of CK, but not a substantial enough to associate that with myalgia. We're looking at one of the issues with statin is many believe it has diabetogenic effects. And the process is it can inhibit insulin secretion through statin because it blocks calcium channels. We also believe that it could also reduce mitochondrial function due to the reduction in CoQ10. We also believe that the pharmacodynamics also shows us that there might be some impaired glucose uptake, and another belief that we could have increased insulin resistance. Now, these are the thought process based on just looking at the data, but the study and the trials that we do know, or that based on this WASCOP, 5,000, almost 6,000 patients showed about 139 patients developed type 2 diabetes. Now, out of 6,000, having 120 or 140 developed type 2 diabetes, it is debatable to say, well, are those patients, are they predisposed to diabetes, or was this just incidental finding? PROSPER trial also showed no significant effect. The PROVE trial showed increased glucose and A1C for atorvastatin. And Jupiter trial shows about 26% when compared to placebo. And I think the largest meta-analysis in 91,000 patients shows about a 9% incidence of type 2 diabetes. But we have to look at the conditions that could increase the statin and side effect. If you noticed when I looked earlier, atorvastatin, one of the high dose statin that we use, especially in patients with cardiovascular risk, you would see that high intensity statins has been proven to be associated with more side effects than lower intensity statins. The female gender, increased age, increased alcohol use, hypothyroidism, and other myocytic events, which could probably be some event associated with patient having on the underlying inflammatory process, could also lead to worsening side effect. Many believe that the physicians are in the pharmacological or the big pharma pockets because it is the number one most prescribed medication. And I think in 2019 alone, just about $10 billion was used in just statins, and that received a significant bump compared to prior years. But the concern is an alternative approach. Remember earlier we talked about that the process is not just increased LDL, but also inflammation as well. And we've seen studies and trials showing that CRP levels correlate with increased cardiovascular risk. So in 1998, Rikers and Cole, they looked at CRP levels as well as HDL and LDL, and they associated both, and they saw that that was as a better prediction of cardiovascular risk when you only look at LDL alone. And we also see an ascending quintile for CRP, in 27,000 patients. As you increase as the CRP increases, so does the cardiovascular events increases. So one of the things is, food for thought. We have patients come in and they cannot tolerate high intensity statins. What do we do? Since the process is a two-pronged approach, not just reducing LDL alone, because we know inflammation also plays a significant role, I think we should, be open-minded as physicians and say, hey, even though our guideline says for anyone with any ischemic cardiovascular patient, we want the LDL below 50, for diabetic patient below 70 or 70 to 100, we should have an open approach where we want to at least have an open conversation, let them know that even if what you could tolerate is a lower dose of statin, as long as we get the anti-inflammatory benefit, we should hopefully have an improvement. I think having that open conversation should help increase compliance. We see here that pravastatin inflammation and CRP evaluation significantly reduces CRP. So statin also helps reduce CRP levels. The nocebo effect. Many patients, when you tell them, I want to put you on statin, they say, no, I don't want. And they will give you the side effect because they're already aware. And I think the nocebo effect needs to be considered, because if they think they might have those side effects, we've seen patients because of that thought process, they do have those side effects. Now, is that a real side effect? Is that Are they imagining it? I don't think so, but I think we need to be aware of that could also play a role. Hydrophilic versus lipophilic, especially in the setting of patients that, they're concerned about fogginess, the thing that, they can't focus while on statins. It might be beneficial to change from let's say, lipophilic to an hydrophilic statin. For obvious reasons, in times, the brain is a big mass of fatty acid, and if we kind of give a medication that is more dissolvable in water as opposed to fat, we should see a decrease in side effect. But I think overall approach, based on what I said earlier, is that we want to start early. We want to advocate for lifestyle modification. We want to advocate for appropriate diet, so that if we reduce or help them maintain a lower LDL at an early age, in their 30s, in their 20s, and keep to a lifestyle that is proven to reduce overall LDL, especially when there's no concurrent, issues like a genetic predisposition, we see benefits. So we want to preach, again, most of these food groups here. All of this help increase the HDL because HDL helps with reverse transport, avocado, leafy vegetables, legumes, garlics, and these are all type of food group that have been known to help reduce LDL numbers. GLP-1 is still in development and it's been proven to be the wonder drug. My recent rotations in the rheumatology clinic, it's also proven to reduce inflammation in patients who have rheumatoid arthritis, and the process is it just reduces overall inflammation. And I think patients who are benefiting or who are candidate for GLP-1, we could consider that. They also, we also know that it also improves overall cardiac mortality, and I think that could also help us in overall cardiovascular risk. So overall, at the end of the day, I think the concern is shared decision making. Starting early, making sure that we reduce LDL early enough that we don't have to worry about, cardiovascular issue at the end, and then having to chase, the numbers or chase, after the patient, and because we think that's when they will get the benefit, when in fact the best benefit is time. Thank you.